Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to be spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors, Jason Lesnick, Samuel Rouleau, Nicholas Stryka, Aaron Lacey, and Clay Smith. Okay, let's go straight to the second article, titled Naloxone and Clinical Outcomes in Suspected Opioid-Associated Out-of-Hospital Cardiac Arrests out of the JAMA Network Open. So this is being talked about quite a bit in recent years, the thought about giving naloxone to a patient who's in cardiac arrest. Now, drug-related OHCAs have increased in the United States, and it's thought to be that about 70% of them are due to opioids. And so if you got a younger patient who's coming in cardiac arrest here, and you suspect maybe it's drug-related, then there's a decent chance that it's due to opioids. Now, at the point where you're in arrest, do I think that naloxone is going to be that helpful? Presumably, if you were arrested due to opioids, it's because of respiratory depression and then hypoxemia, and then as a result, you've progressed now to arrest. And if I think I give you naloxone, and then maybe that'll improve your respiratory drive, probably, I don't think that it would hurt. But it might be too late for you for that to be helpful. Really, you should be ventilating this patient already if they're in arrest, and that should be doing pretty much the whole job. You've replaced the work for them, so I'm not sure that naloxone would be that helpful. Some people have posited that perhaps the overwhelming opioid effect, or even the fact that perhaps blocking the opioid effect, even in normal people, could be helpful regardless. So there is some reason to do these trials to see if it would be helpful. Now, this was a retrospective analysis of 40,000 EMS encounters of adult patients who suffered an OHCA. What they were looking at primarily was whether or not there was ROSC and survival to hospital discharge based on whether or not the patient was given naloxone. Now, for about 7,500 patients, there was naloxone that was given, and ROSC was observed with about 23% of them, and then 11% of them actually surviving to hospital discharge. 2,000 of these patients were estimated to be suspected to have had their arrest as a result of a drug overdose, based on EMS and dispatch data. For this group, all considered, they actually did pretty well. ROSC 32% of the time, and survival to hospital discharge 21% of the time. So after propensity matching, the adjusted odds ratio for ROSC, whether or not you gave naloxone, was not significant. For survival to hospital discharge, it was barely statistically significant, an adjusted odds ratio of 1.18, but that confidence interval spanned from 1.00, so really on the edge here, to 1.38. And it was actually better if the patients presented in PEA, here an adjusted odds ratio of 1.41, but again, that confidence interval goes right near 1 at 1.02. And this makes sense. If you're coming in with a non-shockable arrest, particularly PEA, then you're probably at an even higher chance of having an opioid-associated arrest. Thus, naloxone might help if you can keep them perfused enough for them to actually get ROSC. So great, if it only seems to actually work in a PEA arrest, then heck, you know what? We kind of need more stuff to do in a PEA arrest. But there's definitely a strong argument for not complicating ACLS for something that's not very well proven. However, if you're looking at a younger person, unwitnessed arrest, and you think that there's a good likelihood that it's due to some kind of opioid overdose, then giving the naloxone might help. As for how this data would generalize outside of the US, I'm thinking very poorly because most places do not have the opioid problem that is prevalent in the USA. So in my practice environment, I don't think that I'm going to be reaching for this really unless it's obviously very clear, in which case, heck, maybe I'd give it a bit of a shot. But in the USA, maybe if you want to consider it, it's really not a crazy idea. That being said, do not let it compromise any parts of your standard ACLS because it's definitely going to be a low priority or should be a low priority for you. So don't compromise anything else by giving it. But if it's easy to give and you have a suspicion, a younger patient, unwitnessed arrest, there's some reason to think it might be opioid associated, then it might be a reasonable thing to use. In Spoonful, this retrospective study of out-of-hospital cardiac arrest found that naloxone was associated with improved survival to discharge, but only in PEA patients. So keep that in mind. And then we go to the fourth article, titled Accelerated Diagnostic Pathways for Suspected Acute Coronary Syndrome in Practice, a randomized trial of the 0 and 1 hour versus the 0 and 3 hour troponin testing, out of the Journal of the American College of Cardiology. All right, so there's definitely a lot of talk about which, troponin algorithms people should be using. And Europe has really gone the way of the 0-1, 0-2 hour protocols. If you look at the European Society for Cardiology, these are the ones that they recommend. Now, even for the American guidelines, they are really pushing the 0 and 2 hour protocols. No one's really saying that you should keep using the 0 and 3, which are these sort of older protocols, though many people still are, of course, if they've yet to kind of update to this. And for these protocols, you need high sensitivity troponins. And so if you have that, then you can update. If you don't have that, then you've got to stick with these sort of slower protocols. However, the data that really supports you switching between the two isn't, amazing. But my logic is, if you're doing it quicker, how could it possibly be slower? And the data for safety is really very clear. The 0 and 1 or 0 and 2 hour protocols are very safe and possibly even superior to doing the 0 and 3 hour protocols. So, with that in mind, I think it's really reasonable. That being said, these authors wanted to test it. They wanted to see how much time was saved if you randomized patients that come to the emergency department with chest pain within 12 hours of its onset or peak of symptoms, and randomize those patients to the 0 and 1 or 0 and 3 hour troponin protocols. Interestingly, after doing this, they had similar discharge rates at 4 hours. Although the 0 and 1 hour protocol had more discharges at 5 hours, 42% versus 32%. And the length of stay was significantly improved in 0 and 1 hour protocol, 273 minutes versus 312 minutes. However, studies like this end up with really difficult, protocols to follow. Like a lot of these 0 and 1 hour people were not discharged after one sample, even though they could have been. Now, why not discharge your patient after one sample for the 0 and 1 hour protocol? I'm not sure. But was this perhaps because the 1 hour repeat had already been sent and so was pending? And so people didn't want to send home patients that had a pending troponin result? I think that's rather reasonable, especially with their lab turnaround time of 82 minutes average. So most patients, while you're waiting for the first troponin, you've already drawn and sent the second troponin. And so this is going to delay you sending home that patient. Although I think it's very reasonable for you to just trust the system in this case. If you're ruled out with the first one, the odds of your second one showing that this patient had an MI are extremely low. And I think you would be warranted to have sent that patient home, although I understand why people wouldn't want to. So I think there are huge limitations here that we're kind of stifling the 0 and 1 hour protocol a little bit. And I don't think randomization is the best way to test this kind of thing. You have to get used to a process, a workflow, not to mention the number of protocol violations, as I was saying, was huge, double digits. Anyways, I think that people need to get they need to be given time to become familiar and comfortable with these algorithms. And so if you're randomizing patients between the two, then especially for the new one that wasn't their baseline, then it's going to be really hard to adjust for that. So the fact that we still see some shortening of the length of stay of these patients, to me says that, wow, okay, it really must be shorter. And of course, it is shorter. It's 0 and 1 hours instead of 0 and 3 hours. And with equal safety, even showed in this trial. So it just can't be longer. You've got to admit that the 0 and 1 hour protocol is going to be faster. It's going to be better. I think that's the way to go. And here people were just confusing these poor doctors in this trial, 1/4 of patients were managed against algorithm advice, which is crazy. Not to mention that this was only a daytime process as well. And so if you're working an evening or a night shift, then you're not doing that anymore. This is very confusing for the doctors that are actually on shift trying to do these trials. I think that since the 0-1 hour protocol has really proven itself in terms of safety, it just can't be slower. I think it's reasonable to just do it, to just go for it. You don't need RCT data showing that it's faster. Of course it's faster, and it's safe. I'm on board. In a spoonful, I think that the 0-1 hour protocols do great. They don't miss more than the longer protocols, and they can't really take longer. This RCT data here is flashy, and it does show a little bit of an improvement, but I don't think it's going to be that helpful. Regardless, 0-1 hour protocols do seem to be a little bit faster. Okay, that's all the articles from this week. Let's do a quick wrap up of everything we talked about. From the second article, if you live in a high opioid area, perhaps naloxone might be helpful for your PEA arrest patients, especially if you think that there's a reason that they might benefit from this because you think that it was due to, opioids. Then from the fourth article, we saw an RCT comparing the 0-1 and 0-3 hour troponin protocols for patients presenting to the emergency department with chest pain. It looks positive for the 0-1 hour protocol, even if I think RCTs might not be the best way to test these things out. Now, if you are hearing this right now, then you're not a part of the members feed, and so you missed 3 articles that we covered for members from this past week. What were those articles about? Well, we looked at a big RCT that compared liberal versus conservative oxygen post-ROSC. What's the best way to go? Then we looked at the best initial dose for intranasal midazolam and pediatric sedation. And finally, what are the best interventions to help you with a neonatal intubation? Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.